Is it your Lordship's pleasure that the amendment be withdrawn? It is by leave withdrawn. 37, 38, 39, 40 and 41 have already been debated, so not moved. Amendment 41A, Lord Mawson.
My Lords, the noble Lord Young of Cookham reminded us last Thursday that we have been talking about the social determinants of health and health inequalities for 40 years. It is now time to act. I want to get practical, and my 3 amendments are all about the practical detail, the how questions, about the transformation of the health culture, about new ways of thinking and working. My focus here is on the first small necessary steps on this journey. My Lords, following my speech in the second reading, can I begin by thanking the noble Lord Kamal, for agreeing to meet with both myself and the Chairman and CEO from Ashford and St Peter's Hospital's NHS Foundation Trust in North West Surrey, and allowing us to share with him and his colleagues in more detail the work we have been doing in North West Surrey in recent years. This is set out in Hansard. This work builds on now 37 years of work my colleagues and I have been doing at the Bromley by Bow Centre in East London on the integration and placemaking agenda. The principles of the work in Bromley by Bow are now well known and are being shared with communities right across this country, and this work is now starting to have a national reach through the Well North Enterprises programme, which I lead. I declare my interests. The work in North West Surrey is one further practical example of what happens when you start to take these principles to scale and apply them to the place and neighbourhood agenda, which I am suggesting needs to be strengthened in this legislation. The Minister thought it might be helpful to the House if I first set out the background to my 3 amendments, which are focused on the importance of place and the local neighbourhood, before dealing specifically today with this first amendment on the order paper. What does a modern integrated health service actually look like, and how do we take the first faltering steps towards it? The clues I suggest are in the micro, in the place and the local neighbourhood. My Lords, the NHS is in some difficulty, and much of the narrative that underpins it is last century and now well out of date. The chairman of Ashford and St Peter's Hospital describes it as a financially unsustainable illness service, not a health service. Science and modern understanding of the integrated nature of both life and health has taught us a great deal in recent years about the social determinants of health. The pandemic has ironically forced all of us, indeed the nation, if not the world, to return to the simple question, what is health? We all know nowadays that health is no longer simply a biomedical matter for doctors and hospitals, and indeed never has been so. The Peckham experiment on the social determinants of health was telling us all this early last century, but the NHS in 1948 thought it knew better and chose not to continue with this approach. Health is everybody's business. It is not just the domain of health professionals, hospitals, and just one government department. If 70% of the determinants of health are social, and if our present business model for the health service is unsustainable, then we desperately need to return to this central question of what is health. And what changes to the narrative and services and provisions does the state now need to make to respond to this modern understanding of what health is all about? We need to get upstream towards prevention and early intervention. For this modern generation who take integration for granted, the siloed approach of the state will no longer cut it. My Lords, my colleagues and I have built, over the last 37 years, practical working pathfinder projects in real neighbourhoods with local people. And others may well refer to these in this debate, so I won't waste the House's time now. The Bromley by Bow Centre is in London's East End and is well known nationally and internationally, but there are other projects we have been involved in. Today, the Bromley by Bow Centre is responsible for 43,000 patients on 4 sites in Poplar. We have built with local partners the first housing company, which is resident controlled, which has connected health, housing, education and jobs and business skills, and is today bringing together peoples from many nations of the world who live there around practical placemaking and health and social projects. This housing company now owns 10,000 properties, owns 34% of the land in Poplar, and has many millions of pounds regeneration programme in play. The centre today is visited by over 2,000 people from the public sector and from across the world, who we find are desperately asking the same questions as us. The practical questions, how questions, about how we bring together the health services, local authorities, voluntary and business sectors, and generate a 360-degree response to people's health needs and lives, and the opportunities in local communities. My Lords, this is not a simple matter, but I suggest the place to start is not in the macro, but in the micro, in local communities and neighbourhoods where lots of talent and opportunity lie that is not being tapped, and it never will be if you don't join it up and develop a very different approach. My Lords, in 2015, I was asked by Duncan Selby, at that time the CEO of Public Health England, to take this placemaking work and the working principles of the Bromley by Bow Centre into towns and cities in challenging communities across the country. In partnership with the NHS, local authorities, business and voluntary sector partners, we created 10 innovation platforms in Bradford, Rotherham, Skelmersdale, Doncaster, etc. We did not write policy papers or research documents that, in my experience, often few read. We created practical learning by doing environments. The clues we have found are local, in people and relationships, not necessarily national. My 3 amendments seek to use this legislation to tap into this local talent, to take the first steps on the road to integration, with a necessary focus on the local, the place, the neighbourhood and the community. Health is a social matter. It is not just about private individuals, and we now desperately need to get upstream on the health agenda in this country and move forward. My Lords, this legislation and the integration white paper that is soon to follow can help us all take the first steps in this century in the transformation of the NHS. The micro, I suggest, is the way into the macro. It is not the other way around. Across the country, in local neighbourhoods, at a human level, we now need to create innovation platforms in local places and in local neighbourhoods with public sector leaders and local people, with the willing to support and generate new integrated approaches to health and learn from them. Let 1,000 flowers bloom. My Lords, as we expand our work across the country through practical engagement, we are finding that lots of people already get all of this. Many of them in the public sector and NHS who are desperately frustrated with the present state of affairs. They want to be health creators, but the system is not harnessing their creativity and energy. So often, unintentionally, it is pouring treacle into their projects and disempowering them, creating an ill organisation. This bill and the forthcoming white paper on integration provides us all with an opportunity to start to lay the foundation stones of a new modern health service that understands that health is no longer a matter for one department called the NHS. If what we eat, how we live, if we've got a job, etc., is as important, if not more so, than the doctor, then this is a matter for every government department. And the place to begin to understand what is now needed is in local neighbourhoods across this country. To understand the significance of place and neighbourhood and local people, and to use this legislation to help us take the first steps along this road. The 3 amendments I am putting down, focused on place and neighbourhood, are not perfect. This bill is not perfect, but it might give us an environment to harness the energy that is out there in local communities and generate a health-creating society and a learning-by-doing culture. We need to create a solution-focused culture that is entrepreneurial by nature. The modern world is all about facilitating people and relationships in local communities. This is how the entrepreneurial solution-focused communities emerge. It is not about process and strategy and documents anymore centrally. It is not top-down or bottom-up. It is about an inside-out approach. As my colleagues and I, through the Well North Enterprises programme, have got onto the inside of local communities, we have spotted real opportunities to strengthen life and health that the present structures are failing to see. In my second reading speech, I set out what is happening in one place in northwest Surrey, when the local hospital, 4 local authorities, the voluntary sector and business community started to build working relationships and do things together. Health is now everybody's business. The First Amendment, along with the other 2, are not the last word. They are simply an attempt to get this place-based discussion rolling and empower people at the front end in local neighbourhoods and places across this country through this legislation. Let me just now briefly deal with this first specific amendment. My Lords, let me say first that the ICBs must be clear about what a place or neighbourhood is. Neighbourhoods across this country come in different shapes and sizes, be they a place like Cranley Village in East Surrey, where my colleagues are working on a new integrated leisure and health campus with their 11,000 population, or Addleston, where, with a local authority in health systems in a small town, we are working together on a possible health campus on a street. Here we are looking at 50,000 people. It is not the size that matters, but the local neighbourhood does need to feel real. It does need to feel real to local people and not an invention of the NHS and public sector. It needs to be decided locally. My professional colleagues in the NHS in North West Surrey suggest that place-based groups are health and care partnerships at the level of place, population of about 500,000. Encompassing the key providers, which for my colleagues and I means at least NHS-commissioned health providers in that area, including primary care as well as social care and local government. The neighbourhood is more local, and they would work with local partners to agree these. Only those living and working there can possibly know. The ICS design framework, published by NHS-EI, deals extensively with place-based collaborative and partnerships as part of the structure of ICSs, so they are already recognised as part of the structure. For example, on page 23, the framework states, and I quote, "As part of the development of ICSs, we now expect that place-based partnerships are consistently recognised as key to the coordination improvement of service planning and delivery, and as a forum to allow partners to collectively address the wider determinants of health." End of quotes. So their contribution is acknowledged. My proposal here is that they are formally recognised on ICB boards as voting members. We suggest that ICBs need to serve the needs of place and be led by a true understanding of health inequalities at a granular level. This can only be done through strong representation for those who are tasked with leading at place and thus come with an appreciation of those needs. This is about ensuring an appropriate person with real practical experience of delivering the necessary innovation in local neighbourhoods has voting rights on the ICB. ICBs need to avoid intervening where it would be more appropriate to do so at place-based level, and balanced judgment on this cannot take place without voting place-based members with the appropriate skill and knowledge locally. If the micro is now the way into the macro, then this knowledge on the ICB is absolutely crucial. My Lords, the restructuring of CCGs into emerging ICBs has led to a high proportion of senior ICB posts being occupied by previous CCG officers. Moving to the new model will require new perspectives and behaviours to be introduced, and this will require those who can balance a primary NHS commissioning paradigm and culture with one representing communities, the wider determinants of health, and a wider range of sectorial interests. In reality, this is likely to need to be quite disruptive for a time to achieve the change in approach that is now needed. Through my discussion with health and care organisations, it's clear that in aiming to deliver against the aims of the strategy, the detail of implementation, procurement, practicalities, working relationships, understanding of local issues, specifics of local organisations, funding arrangements, etc., often get in the way of achieving what was actually intended. In setting strategies aimed at improving public health and decreasing pressure on the health and care services, strategies may particularly fail to specify the practical ways in which bringing together broad collaborations of local organisations to work on the social determinants of health will deliver measurable improvements in public health. The people who work in these individual organisations and are or will be part of the place-based partnerships envisaged by the bill are well aware of these issues of implementation. If the strategies designed by the ICPs then are to succeed rather than be frustrated by implementation issues, it's important that the strategies are set within an understanding of these issues. Mandating inclusion of a voting member of the ICB who is nominated by the place-based partnerships, a person of real local experience and track record, to represent them collectively in bringing these implementation details into the design of the strategy, will enable better strategy to be set and better connectivity between strategy and implementation, bringing benefits faster to those the strategies intend to help. My Lords, I apologise for taking so much of the House's time on this first of my amendments, but I thought it important to set out clearly the rationale behind them based on practical experience on the ground over many years. I beg to move.
Catching my pockets, forgive me. Amendment proposed, page 137, line 30, at end insert the words as printed on the marshalled list.
My Lords, I would like to support these amendments, and I especially want to support the noble Lord Mawson. I think it was very typical of him that he started our thinking about what is health, and I'm sure there are many, many answers, but I would think one of the answers might be about integration. And it's not integration on the biggest scale, but it's also integration on neighbourhoods, on communities, on what we now call place. And that is so important. That is the building blocks of all that we're trying to do within the hierarchy of the National Health Service. My Lords, I'm inspired by Lord Morrison. I think he's a man of infinite resource and sagacity, an entrepreneur, and also, above all, a great achiever, based on solid principles that he believes in, and like a man of the cloth, is anxious to spread them to others. And he does, and with really good effect. My Lords, it's no accident that my first report to the government, many years ago when I was Mrs. Cumberledge, I entitled my report Neighbourhood Nursing, a Focus for Care, because it is, I believe, the neighbourhood, or in today's parlance, as I've said, the place, that is really all important. This is what colours how people think, how they behave, how they succeed, and sometimes how they fail. But Lord Mawson has shown, even in the most deprived areas, how they can be rejuvenated and they can thrive with strong leadership, purpose and commitment. The noble Lord's deep, unshakable philosophy is it is patience, it is people, it is the local community who should be the movers and the shakers, to be in control. My Lords, I want to mention Bromley by Bow because it was a really innovative, a new way of thinking about things. And I remember visiting it years ago, not quite when it first started, but when it was beginning to really thrive. Bromley by Bow was the first health centre in the country to be owned by the patients. Long ago, funded in 1984, it began with just 12 elderly patients, a rundown church, and it had just £400 in the bank. Today, by applying entrepreneurial principles to challenge social and health issues, it now has over 250 staff, it is responsible for 43,000 patients, as the noble Lord has said, and 4 health centre sites across Poplar. It operates on 30 sites, even wider, across East London. It has supported local entrepreneurs, and I think what's really interesting it has actually built 93 small, medium-sized enterprises. This is people helping themselves and ensuring that there is employment. Through a charitable structure, a housing company, it has and is controlled by the residents. The housing company now owns 10,000 properties and 34% of the land in Poplar. My lords, I think this is remarkable. It's a remarkable achievement in a very poor part of London. It is effective because it recognises the health and wealth are profoundly connected, and not in huge municipal buildings, ivory towers, remote from their populations, but by the people who live there and who work there in that particular area. The schemes are intertwined with the population. They are neighbourhood schemes, and they are recognised as such. They are valued by being part of the destiny of a place in which local people live and work. My lords, I visited Bromley by Bow, as I said in the early days, and I am really disappointed by my GP practice in the village in which I live and I grew up in. My father, one of 2 GPs, knew his patients literally inside and out. He knew who was getting off with who. And as his children, the first thing we learnt was about confidentiality and how to respect it, because we heard all sorts of things. He managed to get a health centre built, and it is called that. Above the entrance to this building, it says the health centre. But today it has been renamed the medical centre. It is transactional. It is a service that is not about health. It's about transactioning to patients what the doctors think they need, but it's not about health. So the practice actually shuns even things like social prescribing, which is prevalent in many areas. And it is also very careful not to involve the community. The Friends of the Health Service have become disillusioned. They established about 20 years ago, and they are fed up. They are fed up with what is going on. And 2 weeks ago, they closed that particular organisation. My lords, the noble Lord Morrison, in his 41A, seeks to use the new world of integrated care boards to ensure local representation is guaranteed. And we've had a lot of debate through this House on who should be on what board and all the rest of it. But I think the problem is, when I've listened to those debates, and there was a big one last Tuesday, I was very struck by people were talking about the big battalions. I listened to the debate, and I could see that people were really trying to ensure places on the integrated care boards which were representative of the big battalions. That's understandable. They are the component parts of the NHS, and there are parliamentarians who see this as the only way forward. Well, the noble Lord Mawson has shown us other ways, but it is a struggle. Today, the Bromley by Bow Centre is having to deal with far too many sources of funding from the public sector. The money from the Treasury is dispersed to the silos: education, local government, other agencies. Too much time is spent by the centre trying to put back together again to deliver integrated projects. The centre runs hand to mouth, even after all these years, because mainstream funders in government don't recognise what the centre actually does. Schools, treatment centres, tertiary colleges, hospitals, traditional health centres are well understood, but Bromley by Bow doesn't fit any of these traditional silos. So, my lords, I do welcome this amendment and the others which follow. The noble lord is trying to free up the claustrophobic traditional ways of not only working, but equally important, of thinking. But the dilemma we face is this. Warm words are given that we must not stifle innovation. But innovation is challenging. It's uncomfortable. It was Henry Ford describing his new invention, the motor car. He asked the public what they thought of it, what they would like. And the reply he got was, just give us faster horses. We have a serious dilemma as big government departments, especially the Department of Health, is about providing the same standard of health, the same provision across our nation. And again, we had a debate on that concerning Scotland and Wales and the other countries. But, my lords, even the nation grumbles as soon as they perceive a postcode lottery appearing. Trying to square this circle is really difficult. The department seeks change through laborious systems. That is the tools they have. Big departments deliver to the nation through their own power lines. Lord Mawson's amendment threatened a short circuit. That might set the structure alight or give the department an electric shock. That is no reason why not to try. People of stature and proven trustworthiness, competent and prepared to take responsibility for their innovations, prepared to report to the department, say every 2 or 3 years, an audited evaluation of the scheme's progress and outcomes. These people should be supported. And I think it might help to square the circle, because if the funders of public money have to be accountable, this is one way of doing it. So I not only support innovation, I support these amendments. I urge the Minister to risk his all, both ministers on the front bench, to risk their all, to let new ideas for places in need, through special workable collaboration, have their head. If we want to level up, then let us be brave and let sparks fly. Because it's time to back and get behind people with a proven track record who are entrepreneurial, not people who talk and write reports about it. The Lord Mawson has taught us the future. It's about creating a learning by doing, as he mentioned in his introduction. That's the culture we want in the NHS, where the whole system learns through best practice on the ground, in real places, with real people. Where there are things not working, let people, like Lord Morrison, interview and turn problems into opportunities. My lords, he spent his life just doing that. Finally, I do believe seeing is believing. And I would like to encourage my noble friends on the front bench, the ministers, to go and visit Bromley by Bow. As a past minister, Sir Brian Mulwiney, he did in the past, and he ensured the future of this enterprise for a few more years and enabled it to flourish. Now, my lords, I know ministerial diaries are a real challenge. I've had one. But I can assure my noble friend that a visit to Bromley by Bow will never, ever be forgotten, and it will make a deep impression.
Can I just ask for some clarification from the noble Lord, Lord Mawson, because both the noble Lord and the noble Baroness Cumberledge have referred to 3 amendments, but there's only one that I can see. So I would be very grateful if you could enlighten me as to which the other 2 amendments are that we might be addressing in this debate.
My Lords, there's just one of my amendments in this debate. The other 2 amendments come further on in the month.
My Lords, I've signed, and it's a huge pleasure to follow both Lord Mawson and Baroness Cumberledge in this debate. I've signed and strongly support all Lord Mawson's amendments. We have riches yet to come. But to ensure that integrated care boards are closely connected to local communities, and his later ones to ensure that local solutions are prioritised and that procurement is firmly rooted in local communities. But I'm only going to speak to this amendment, 41A, and I want to give an example of where both Lord Morrison and I have been involved. Another project beyond the one that the very important Bromley by Bow project that Baroness Cumberledge talked about, and that's St Paul's Way Transformation Project, the health, education, jobs and skills and community campus, which started in 2006. And it's a great example of a response to the local challenges faced in an East London neighbourhood very close to Bromley by Bow at that time, with failing health and education services and community relationships. And this transformation project was focused on integration from day one and has been a huge success. Now, Baroness Cumberledge talked about Lord Mawson's extraordinary track record as a social entrepreneur, and this project was launched by Lord Mawson in partnership with the NHS and Tower Hamlets Council, and brought together the local authority, the local school, the GP network, the local housing association, Poplar Housing and Regeneration Community Association, and the Diocese of London to bring about transformational change in and around St Paul's Way, a main street running through Poplar. Together, they built a new secondary school, new primary school, new health centre, new mosque, new community centre and restaurant, new park, new street scene, and 595 new homes. And in parallel with this, the quality of the local leadership and hence of local service provision was transformed. The failing secondary school moved to Ofsted Outstanding, the failed GP practice was replaced, and its successor became CQC Outstanding, and the independently monitored resident satisfaction level is currently 85%. The St Paul's Way project has been a great success story of local partnership with other actors. For example, near neighbour Queen Mary University, the governing body of which I chair, with 2 campuses in Tower Hamlets, and which is intimately involved in the governance of St Paul's Way Trust School, helped design and develop the new science labs at St Paul's Way Trust School. This is in the health building, which the school use, and has taken space for its School of Dentistry. We've taken space for our School of Dentistry and DNA research in the building. Partners in the local schools, the GP practice and the Housing Association have played an important role in recent years as they shared their work and experience with communities in towns and cities across the north of England and now beyond. Yet the project now faces major challenges as outdated NHS procurement systems are now in danger of undermining the good work it's been doing for over a decade. In the midst of this project being put together, originally, the PCT procured a primary healthcare provider with no London experience, let alone any local experience. After 2 years, they surrendered the contract because they hadn't understood that primary healthcare is very different and costs a lot more to deliver in Poplar than it does in affluent suburbs. And this experience is an illustration of the importance of there being a neighbourhood voice in the making of decisions by the NHS, which, if they are got wrong, could damage the ability of local integrated partnership to function and develop effectively at the neighbourhood level. There is an opportunity to address this in legislation. In this light, how can the government really make integration a reality? This is a clear example of disconnects that will be replicated on other streets across the country, and a demonstration of what happens when the NHS procurement systems and policy do not take place in neighbourhoods seriously. Health is about bringing people and communities together, not undermining them. The solutions are often local, not in large outdated systems and processes, and this local approach needs to be embraced. It is at the 50,000 person neighbourhood level, not an enormous 8-borough ICS, where integration aimed at innovation in prevention and recovery can be most effective. Neighbourhood has to be understood, valued and given leverage in the system and flexible use of budgets. It's at this level that the actual practical interventions can happen. It's here that schools, housing, job opportunities and community action can happen. Neighbourhoods can act with speed and agility. And I do suggest, the Noble Baroness has suggested a visit by the ministers to Bromley by Bow. My lords, I would equally suggest a visit to the St Paul's Way Transformation Project. My lords, this amendment is as much about creating the right culture as the right representative structure. And I hope that the government will accept this important amendment and the other amendments put forward by Lord Mawson on this subject.
Lords, I've been very happy to sign this amendment too, and I will speak just to this amendment and congratulate both Lady Cumberledge on a very, very moving speech and Lord Mawson on a very comprehensive speech. So I intend to be brief and to say simply that I think in the logic of everything that I heard in previous debates from previous members this afternoon, this amendment is even more important than I thought. Because when the House is discussing how to make the ICBs as effective, as powerful, as salient, as comprehensive as possible for the people they are bound to serve. All these factors need to be taken into consideration. But the power of place itself and the opportunity that the ICB creates to make this manifest, just as Lord Morrison has made manifest in Bowl, is a unique and a highly innovative opportunity, one that may not come again. And what he proposes is extremely modest. It's just to give one person from the partnership voting power. But it's essential, and it's in the spirit and the logic of what place-based partnerships are intended to do. It means that there will be, on the ICB, people who can bring near sight and access, reach into the community to the decisions of the ICB. They can help inform those decisions to bring that particular knowledge and sensitivity of the lives that people live and what they're faced with and their specific choices. And I think they are one of the most optimistic partnerships and ideas that we've had in this House for some years. I have spoken many times in this House on the power of place and what it actually can achieve and how it affects people's lives, and particularly their health. And we published quite a useful report. Lord Clement and Jones and I were on the same committee a few years ago on the Building Better Places, where we actually diagnosed the relationship between good design, good building, good environments, and good health. And maybe actually that's a time to get that back off the shelf. But what is useful also is that the partnership principle is alive and well, and it is generating good practice. There's increasing evidence that it works, there's increasing exchange of ideas and skills, and we are learning all the time about what is possible. There's nothing to be said against this. The expertise that the partnership can offer to the ICB may come from different partners. I'm particularly interested, for example, in the role that housing providers could produce. And I'm sure Lord Best and his amendment will speak to this. They will bring a perspective from the point of view of the tenant and the diseases of poverty in poor housing, which that board will need to hear and act on. But they equally could be mental health providers who know why it is that young people can't access mental health. They know where the bottlenecks are, and they know what is needed. The partnership will choose for itself who will represent it, who will have the most effective voice, who knows the place, and that has been said before this afternoon. But the essential criteria is that they really know what would be delivered best. Well, Lords, indulge me for a moment with a bit of history, because this has got a very, very long history. In 1889, William Booth, in his maps of the life and labour of London poor, literally mapped disease against places and housing condition, the stews of London, in a graphic illustration of where the worst concentrations of poverty were. And in so doing, he redefined both health and poverty. And significantly, the first evidence came from the school boards and the local policemen, real partners in place. He certainly understood that you could not reduce inequalities or promote good health unless you have decent housing, fresh air, a decent wage. Now, my lords, the geography of poverty hasn't changed that much. It's still the geography of disease and premature death, and the prescription hasn't changed at all. And this amendment is an opportunity to put that into immediate and direct practice. I hope the Minister doesn't need much persuasion about this. It really is a very simple amendment and a very necessary one, and he would certainly have the support of the House in entertaining it.
Lords, I'd better start just by declaring my interest as an advisor to Well North Enterprises, which was mentioned by the noble Lord, Lord Mawson. But let me congratulate my noble friend Lord Mawson and the other lords from the different parts of the House who've all spoken on this amendment, making the whole issue extremely clear. I just want to make a few very specific points. The first one is that we've heard about great big projects that are making massive difference. Every noble lord in your lordship's house, I'm sure, knows of smaller examples that are making real difference and how important those small examples are and how they add up, as well as these larger examples as well. Second point I want to make quickly is this is about change that's happening, it's very local, but actually this is also about what's happening globally. And I've quoted in this house before a saying by a friend of mine who used to run the Ugandan Health Service, which is health is made at home, hospitals are for repairs. Powerful expression where one might say health is made at home and in the community and in the workplace and in the school. And also it contains the notion that health can be created. It's not just about preventing disease, it's about creating health as well. But more recently, globally, noble lords may like to know that the WHO published a Geneva Charter for Wellbeing at the end of December, which explicitly talks about the creation of a well-being society. So this is a global movement that we are talking about here, and not just a local one. Although, as Lord Morrison has continually emphasised, this is about practical changes at the local level and how important that is. Final 2 points I want to make are, and this is probably the very big one, is that when we come to think about the membership of these ICBs, it's really important we have the insiders there, the clinicians and the people who know how the systems work, but actually we also need some outsiders there as well. And if I can refer to the debate on the last amendment, this is not just about different skill sets. This is about different behaviours and about doing different things in different ways. Those of us who've worked within the system are bound by the system and think in terms of the system and all the regularities of the system, if you like. The sort of people that Lord Mawson is talking about don't start by thinking about the system. They start by basing things on relationships. Learning by doing, a point that he has emphasised. So there are different ways of doing things. So I do think that it's really important that as these boards are constructed, they bring people in with that different approach alongside the great knowledge and skill that NHS and other clinicians bring to this. And I know that bringing those two parts together, the insiders and the outsiders, is where we're really going to get success. When we get people working together and understanding how to do things. So my final point, really, is this amendment proposes a person representing these groups or drawn from these groups on the ICB. I have to say that, I do recognise the debate that's been going on about having, tying the hands of local people about what's happening on these ICBs. And I do understand that as these things get larger, not only are you including more voices, you're also implicitly including more vetoes. And the health service has over the years suffered from having too many people with too many vetoes in terms of actually making change happen. So I do understand some of the complexity and the difficulty there. But the final point I want to finish with, or the final part of this point, is to ask the Noble Lord the Minister a question. I asked him earlier the question about really saying, I don't know if I'm alone. I'm not sure that I understand how in reality all these bits are going to fit together and work together in this new structure. And I know that he has committed earlier in an earlier part of the discussion on this bill to providing us with a diagram and perhaps a bit more of an explanation of how they all work, because I can see the complexities of everything that we're talking about here can be really difficult. But my single point here, I think, that I just want to reinforce is the importance of not just having the insiders in the decision-making process, but also having these more disruptive influences. And it's not just about skill sets, it's also about different ways of thinking and behaving, and a focus on relationships and not just on systems.
My Lords, I would also like to rise to support the Noble Lord Mawson in his amendment and congratulate him and his colleagues on the extraordinary work they've done. I support this bill, my Lords, precisely because integration will be key to delivering the health outcomes that we all seek. But I worry that if this bill is just a rearranging of the organisational deck chairs with exactly the same people in different organisations with different three-letter acronyms, we won't actually change anything at all. I think over the course of the nearly 3 days that we've now spent in committee and in second reading, there is real cross-party agreement about the nature of the problem we're trying to solve. Each debate we've had over the last 2.5 days, whether it's been on health inequalities, on mental health, on the social determinants of health, on person-centred but digitally enabled care, actually there is extraordinary cross-party agreement on the nature of the problem. And as the Noble Lord Clement Jones said, I think really we're debating and disagreeing more on the means to the end than anything else. One of the means to the ends is local. Real, genuine, local ownership and local leadership. Like many others in your Lordship's house, I've made the pilgrimage to Bromley by Bow. I've also been to St Paul's Way. When I first joined the NHS about 5 years ago, I was told to go to Bromley by Bow, and by a number of NHS insiders, I was told how brilliant it was, but how impossible it was to replicate it anywhere else. Go and have a look at it, Dido, they said, because you'll be amazed and impressed, but no one's worked out how to spread it. What I've actually discovered, as we've heard today from people with far more experience of place-based leadership than I, is that actually brilliant though Bromley by Bow is it's not alone. And actually, there are fantastic place-based leaders in communities all across the country. And it's those local groups and local leaders that actually, my Lords, we owe the exit from COVID to more than anything else, I suspect. And personally, I've had the privilege of working alongside them. So I've been to North West Surrey with the Noble Lord Mawson, but I've also been to Wolverhampton, to the Guru Nanak Sikh Gurdwara, one of the very first local testing sites for NHS Test and Trace. I've been to Gloucester, spent time with Gloucester FM, a local community radio station, that for the first time in their existence got funding to run an advertising campaign to encourage people to come and get vaccinated in their local community. That was the first time they'd succeeded in working collaboratively with their local NHS. I've been across the country in the last 2 years talking to people from groups that feel excluded, whether it's the Gypsy Roma community, travellers, refugees, taxi drivers, faith leaders in a whole host of communities. They've all told me, in both my previous roles as Chair of NHS Improvement and as Executive Chair of NHS Test and Trace, they all told me in different ways how they felt excluded. Not just excluded from the NHS, excluded from society in general. And they also said, generally to a man and a woman, and we know this, those of us who have worked within the NHS, how hard the NHS is to work with when you are that small outside local group. So it is that with that knowledge base, my Lords, that I wholeheartedly endorse the spirit of the Noble Lord Mawson's amendment. With a but. I've been consistent in the last 2.5 days of committee in being very nervous about adding specific roles and experiences to what is now a growing list of characteristics and past experience that we would all like to see in this new three-letter acronym NHS entity, the Integrated Care Board. So I'd like to pose a question to my noble friend, the Minister. because I think it's really clear we need these local voices, that we need the grit in the oyster, as my noble friend Baroness Cumberledge referred to, the difference that the noble Lord Crisp is referencing, people from outside the system, if this new reorganisation is going to be anything more than just a rearranging of the deck chairs. So I'd like to ask my noble friend the Minister how we will ensure that those local voices are genuinely heard in an integrated care board, please.
I rise to support the amendment in the name of my noble friend Lord Mawson and others, and in so doing wish to congratulate him for his very thoughtful introduction to his amendment. I mean, it is very clear that one of the most important aspects, the purpose of this bill, is to ensure integration and to ensure that integration at a local level. But the purpose in that integration must surely be, indeed has been confirmed by the noble Lord the Minister, to improve health outcomes for the entire population. And it's well recognised that that can only happen if the social determinants of health at a local level in communities are addressed appropriately and effectively in a way that our health system has not been able to do to date. If we accept that to be the purpose, then that local integration, that focus and understanding on social determinants of health and responding to them and responding to those local needs needs to be secured in the organisation of the integrated care systems and their boards. And as we have heard from the noble Lord Mawson and others, to achieve that, one has to not only understand, appreciate and hear the local voice, but be clear that the culture that is established in these systems is a culture that is responsive to those voices and determined to act on them and the understanding of the local situation, and in particular those social determinants that extend far beyond what has been traditionally and can be delivered through the delivery of healthcare alone, and focuses on other issues such as housing, education, employment, and so on. And it would be most helpful for the noble Lord the Minister in answering this particular debate to explain how that is going to be achieved in the currently proposed construction of the integrated care boards. Of course, one recognises that Her Majesty's government is deeply committed to this agenda. But it's clear that if these boards are not constructed in a way that they are able to change the culture and drive in an effective and determined fashion a recognition of those social determinants and the opportunities at a local level to address them, then much of the purpose of this well-meant and well-accepted proposal for greater integrated care at a local level will fail.
My Lords, I wasn't intending to, but I would like to contribute to this debate. Firstly, just to say thank you to the noble Lord Mawson for his Amendment 41A, which, although modest in its scope, very modest amendment indeed, has initiated, I think, an extremely useful debate with a lot of important issues. I don't want to add a lot of material to the debate, but I do want to focus on what the questions are, I think, which emerge from it. Won't surprise noble Lords to know that I've been to Bromley by Bow, in my particular case, as Shadow Secretary of State and as Secretary of State in the company of Sam Everington, now Sir Sam Everington, who was an advocate then and now for clinical commissioning. And I will put on the record that I think we must not lose sight of the value of clinically led commissioning in delivering best quality outcomes in healthcare. I don't think it's the government's intention at all to lose that, but I think we just need to make sure that it's not lost sight of. But my point in contributing to this is to say, taking the example of Bromley by Bow, where did they get to? They had Tower Hamlets Clinical Commissioning Group, which I think was once, on one occasion, was the Clinical Commissioning Group of the Year, an exemplar in this field. That clinical commissioning group and other clinical commissioning groups eventually came together in a very large conglomerate operation. I think my noble friend or noble Lord Kekar will know it very well. The 7 CCGs in northeast London, about 2 million population, came together eventually in one very large organisation. Now, the question I have to ask is this. We start out with clinical commissioning groups whose understanding is that they need to work with local authorities through the health and wellbeing boards. They needed additional powers for the integration they needed, absolutely fine. But what we've actually ended up with, which I said at second reading, is that the NHS and indeed the management of the NHS are getting themselves into a terrible twist in terms of organisational structures and geography. Noble Lord Mawson talked about place-based partnerships with a 500,000 population. Noble Lady Baroness Cumberledge talked about place and localities with 50,000 population. My point is, the 2012 legislation, even if it didn't achieve what it was intended to achieve, at least said, well, the clinical commissioning groups can determine whatever population they like. Let's set it up at whatever level makes sense. They've ended up with probably about 300,000 average, but it goes from 800,000 to 30,000. I don't think we should get obsessed about this geography. We should still, I think, even at this late stage, be letting the ICS achieve what it needs to achieve by being a relatively large organisation with the capacity to do population health management, with the ability to manage commissioning at a high level, and bigger, and this is the key to why size matters, and bigger and in the jungle than the big provider trusts. Going back to what my noble friend Lord Hunt of the Wirral was saying previously, making sure that the conflicts of interest don't arise and the providers don't run the commissioning. But then, if you've got a big ICS, there is a big gap. How is place and local leadership going to be incorporated? Noble Lord Mawson rightly talks about it, and it being represented on the Integrated Care Board. But where is it in the bill? I know that the NHS England and NHS Improvement and the Local Government Association have produced guidance and have referred to place-based partnerships as being an integral factor in the bill, but I don't see it in the bill. It isn't in the bill. What I want to know is, how are we going to put it in the bill? How are we going to make sure that this happens? How are we going to achieve the objective that the Integrated Care Boards genuinely, in my view, this is what they should be doing, genuinely integrate health and social care and integrate the whole range of those services in order to deliver health? And I might say that the Integrated Care Partnership, incorporating health and wellbeing boards, should be about achieving the social determinants of health. I depart from my noble friend Lord Kekar that I don't think it is the job of the health system to deliver the social determinants of health. It is the job of government to deliver the improvement in well-being and health that is implied by moving in the right direction on the social determinants of health. And I think the Integrated Care Partnership is where that should happen. And I see no reason why the clinical commissioning groups cannot be place-based, clinically led basis for creating place. They're going to be abolished, but in that sense I'm saying, well, why are we doing that, since they already exist? And secondly, the health and wellbeing boards, to my mind, to repeat a point, are the basis, in my view, for creating an integrated care partnership, which is the essence of wellbeing. And it seems to me that is a much simpler structure. I was accused a decade ago of making it all too complicated. I think it's now at risk of becoming even more complicated. And let's at least start with what we've got, which is exactly what they did in North East London. You know, they came together and said, well, look, we can create, for the 3 boroughs of Newham and Tower Hamlets and Waltham Forest, we can create something which is large enough to work, and inside it we have the borough-based relationships, which are the method that we apply ourselves locally to delivering the health and well-being that we hope to achieve. So I'm really asking that question of my noble friend at this stage. as we're really still just starting out on this, show, if he would be kind enough to show us where in the bill the essential element of place is to be inserted. And then I think we can actually debate it further and put it into the bill in its right form.
Thank you for what's been a very, very interesting debate, and I think probably an important debate. And I'd like to thank the Noble Lord, Lord Mawson, for his amendment, and I look forward to the further development of this thought process which he has put before the House this morning. Of course, it isn't new. I started my working life off working for Michael Young, the great sociologist, in Bethnal Green, and we were talking about ethnographic research in our neighbourhoods and at places, and it was about giving people who lived in those places the power and and developing their own leadership of what they wanted to happen. In those days, actually, when he started doing his work, of course, it was about regeneration of inner London, the bomb-strewn East End. And indeed, I had the great privilege to run the Young Foundation. I took a couple of years off from this job here to go and run the Young Foundation a few years ago. And we were doing exactly the place-based work that the Noble Lord, Lord Morrison, is talking about. So the Noble Lady, Baroness Harding, is completely right. There are many, many of Bromley by Bow type programmes across the country, and thank goodness for that. So the Noble Lord, the Minister, is deciding to go on trips to places. Bromley by Bow, of course, is important. I went to Bromley by Bow when it started out, when I was the founding chair of Social Enterprise UK. And the Noble Lord, Lord Lansley, is quite right that actually it's brilliant, it's wonderful, it does great work, but why hasn't it been replicated? This is a question and a discussion I've had with the Noble Lord, Lord Mawson, on and off over many years. But there are many other types, and I suggest the Noble Lord might go to Manchester, might go to Bradford, he might go to Nottingham, where there are some brilliant programmes where this place-based delivery of healthcare and other care is thriving. And I think the consensus breaking out between myself and the Noble Lord, Lord Lansley, is, of course, actually, this bill is an opportunity, and how and where in this bill can that place-based initiative be expressed? Where is it? How can it be encouraged? I found the work that the King's Fund had done, where they've done a piece of work developing place-based partnerships as part of the process leading up to the bill, which was published last year. And they've got some very interesting and useful things which express the sort of sentiment, but in NHS speak, that the Noble Lord, Lord Mawson, has been talking about today, and the importance of connecting communities, jointly planning and coordinating services, making the best of the financial resources, supporting the local workforce, driving improvement through local oversight and quality provision. And there are certain elements of this which need to be there, which need to be built into this bill somehow, even if possibly as enabling, because what they do mean is building multi-agency partnerships which involve local government, NHS organisations, voluntary service organisations, social enterprises, and the communities themselves. And what the Noble Lord, Lord Mawson, has rightly asked is, how is that, and the question for this amendment is, one voting ICB board member to be nominated by place-based partnerships. And that may or may not be a good way forward. But actually what we're trying to do is do systems change, and it may or may not be the way to do systems change, is to put one person on a board. But it's a very, very good place to start. So we are, on these benches, very interested in how this develops and want to be part of the discussions across the House about how we do that.
My Lords, there's no one better placed, whether inside or outside your Lordship's house, to advocate for place-based partnerships than the noble Lord Mawson. And I know he will remember that one of my first visits as a health minister in 2010 at his invitation was to Bromley by Bow. What I learnt that day made a deep impression on me, so I, like many noble lords, need no convincing of the case that he and other speakers have made today. I'm aware that the noble Lord Hunt of King's Heath has tabled an amendment 165, on place-based arrangements to be debated by this committee later in our proceedings. So no doubt we will cover the issues in more detail then. But for now, let me say that the government absolutely agrees with the importance of having strong place-based elements in ICBs. Place-based structures will play an important role in delivering healthcare services for their population groups, and we expect there to be open and clear lines of communication between the board of the ICB and place-based structures. So how is a sense of place given, as it were, tangible substance and meaning? I would argue that we don't necessarily need the bill to articulate the reality. At a very basic level, an ICB will cover a geographic area. We would expect ICBs to be closely linked to their places via bodies such as health and well-being boards, where they will sit as the successor bodies to CCGs, and local authorities. ICBs will sit on the integrated care partnership, as well as the health and well-being boards. Both bodies are vital in bringing together health, social care, public health, and potentially wider views as well. And that will be part and parcel of delivering their duty to involve patients and carers and the public when discharging their functions. My Lords, we expect ICBs to have place-based structures in place, but we don't want to prescribe what those structures are. As the noble Lord Morrison said himself, we don't want ICBs to think that place-based partnerships are achievable via a central blueprint, or that a set of instructions from above were likely to be a substitute for learning by doing and local relationships. What we shall insist on is for an ICB to set out the arrangements for the exercise of its functions clearly in its constitution. Different areas have different needs, and I hope it is a point of agreement across the committee that a one-size-fits-all model would not be appropriate. I heard what the noble Lord Mawson said about the need to join up strategy with implementation and having an individual whose job it is to oversee this. That may often be the way that ICBs choose to go, but we feel that requiring voting rights for place-based partnerships is simply not necessary, and it would come at a bureaucratic cost. Our view is that we shouldn't attempt to over-legislate for the composition of ICBs. Instead, we should let them evolve as effective local entities to reflect their local needs. I hope the noble Lord Mawson will forgive me for not wanting to pepper the bill with requirements and duties for ICBs. If we want to make 1,000 flowers bloom, I don't think this is a way to achieve that. I fear that the amendment would actually risk making the boards less nimble, undermining their ability to make important decisions efficiently. Now, having said that, I'm not at all suggesting that the centre should wash its hands of this agenda. So in answer in particular to my noble friend Lady Harding, NHS England will be keeping a close eye on the constitutions of ICBs, and we expect the assessment that NHS England makes will include whether there are suitable place-based structures and whether there is clarity about the expectations and roles of those structures, including what they're responsible for commissioning, what powers have been delegated to them, and what resources they are responsible for. So with those points in mind, and looking forward, as I say, to our further debates on the subject, I hope that this assures Noble Lords that the government has got this agenda very firmly in its sights, and that the NHS England has equally, and that therefore they will feel able to withdraw their amendment in the knowledge that I'm sure we shall have further things to say on this important subject.
My Lords, can I thank the Minister for those thoughts and comments, and can I also thank the Noble Lords who supported this amendment and this very encouraging debate. The purpose of today was to open up a discussion about these issues, and I think myself they've been very well led, and there's a discussion I think needs to go further, and I certainly would like myself to take further the discussion with the Minister and colleagues around the implications, because my concern is to ensure this understanding the significance of place and neighbourhood and the micro is absolutely clear at an ICB level, and senior colleagues in the NHS where I'm working are warning me and to be very careful about this, because the danger is that fine words will be used. Others have said this. This is not about the words. This is about understanding the actions that now need to take place to really transform the health service. And the micro and the macro really need to learn to dance together. And that will not happen unless there's great clarity on it. But a conversation, hopefully, to take them further, and it's been a helpful conversation. A few final thoughts. It's been very good to have colleagues from different parties and very different backgrounds coming around this discussion. I personally found it a very helpful discussion, because this is not a party political matter. This is about the next 20, 30 years of the National Health Service. There's likely to be different governments, different parties with responsibility, but laying the foundation stones correctly and getting the detail right, it is all about the devil and the detail, in my view, is really, really important. Very interesting to hear bits of the history. I mean, it was Lord Michael Young who came to see me many years ago in Bromley by Bow, precisely because he got very interested in what we were doing. It wasn't that he just joined us as a community and became our patron, as we had patrons from different parties, as a matter of fact. Lord Peyton was a patron for many, many years from the Conservative Party, as with Lord Eddles from the Labour Party. He ended up asking me to marry him, so I actually had to do the marriage and the baptism of his child. So there's a long history. And actually, Alison Trimble, my former chief executive, was called to work in the King's Fund precisely to help it understand the devil and the detail of what we were discovering. So this brought back many memories for me, this debate. I think the last few things I'd say is it's important in this journey that we create a learning by doing culture. A learning by doing culture is very well known to science. I work in part of my life with Professor Brian Cox, who knows quite a thing or two about science, and I think the reason we get on is because we understand that science and entrepreneurship are profoundly connected. Not just the health service, the whole of the public sector, in my view, needs to now embrace a learning by doing culture, which moves beyond strategy and process into learning from practical things it doesn't do. Finally, I'd just like to thank Susan Rankin, the Chief Executive of Ashford and St Peter's Hospital, and the Chairman, Andy Field. Susan is a brilliant Chief Executive, and Andy is a rather excellent Chairman, for joining in this conversation with the Minister and colleagues, who I think would agree, as a hospital, have been very brave, now with 4 local authorities, to set out on a journey and lead the way in Surrey of what this might mean when you start to move it to scale. But having said that, I'd like to beg leave to withdraw this amendment.
Is it your Lordship's pleasure that the amendment be withdrawn? It is by leave withdrawn. Amendment 41B, Baroness Finlay of Llandaff, not moved. Then we come to Amendment 42, where Baroness